Happy Teach Me Tuesday! My name is Lisa Houston and I am a clinical nurse educator in the NICU, and today we are kicking off our March series. I've decided in my head I'm into these new series. Remember we did an NRP 4-parter in December, and then in February we did the congenital heart diseases. So I've named this month's series New Beginnings. And you might think this all is going to have to do with delivery and labor and birth and the first bit of life, but I'm going to twist a little bit on what new beginnings can mean for us in the NICU. So today we are going to talk about that beginning of life, the beginning of our entry into the NICU and the maternal conditions that affect both baby and mom during pregnancy, delivery, and maybe even the beginning of a NICU stay, and in some conditions for life for some of these conditions. So let's start by reviewing. When we think about this link between the mom and the baby, if you've watched any of my videos, especially the early ones, you will know that I have a deep love and appreciation of the placenta. But what the placenta is a big representation of the mom's health, the maternal health condition that she has going into her pregnancy and in her pregnancy and the things that she is affected by. So sometimes these are things that are already pre-existing, whether that is maternal hypertension, diabetes, depression, rheumatoid arthritis, any of those diseases that affect the mom throughout her life. But we also have those things that come on because of pregnancy, including pregnancy-induced hypertension, preeclampsia, gestational diabetes, and then anything that's going to happen with the placenta that kind of is affecting that mom-baby dyad. So all of these things kind of come together. They affect fetal growth and development. They can have long-term effects on mom and baby. And also it just is more stress on that carrying parent, that mother who is carrying the baby. So let's look into some of these. This is a fraction of what we could really investigate. We are only learning more every day about how a pregnancy is affected by the conditions the mother is exposed to, which in turn is exposing the baby to some of these conditions. So really, I feel like we don't even know all of it yet, especially with genetics. I mean, let's not get started on genetics. This is not a genetics review. That will be coming in the future. But it really is we're touching the surface. So let's just go over those common ones, especially for things that affect our babies as they come into the NICU. So if we think about maternal hypertension and preeclampsia, you can have pre-existing hypertension prior to pregnancy, or you could have it during pregnancy, or it can lead to preeclampsia. I am one of those lucky few, says no one ever, who developed preeclampsia during my pregnancy at the end. And really what preeclampsia is a reflection of what's going on with the placenta. So maternal hypertension is affecting the blood flow to the placenta. The placenta is then in turn reacting and restricting its blood flow, which is then restricting what it's getting to the baby. So for the mom, some of these signs and symptoms and complications she's going to see are headaches, placental abruption, preterm labor, seizures, kidney failure, stroke, death, right? We 100% have seen moms have eclamptic seizures. If you've seen one, it's terrifying. We've seen these eclamptic seizures. We've seen them where they cause moms to go into cardiac arrest and then they end up in the ICU post-delivery. So it is very intense. Preeclampsia is specific to how each placenta is implanting into the uterus. So for me, speaking from my own personal story, I had preeclampsia with one pregnancy, but not with the other. Whereas gestational diabetes, which we're going to talk about soon, is one of those things that usually recurs with every pregnancy and tends to get worse. Preeclampsia is not that. I remember when my midwife told me that, and I was just kind of reassured and okay, each pregnancy we're going to take as its own, and I did not have it with my second one. So for the effects on the baby, they can be SGA or IUGR. So what you're thinking about is there's restriction to the placenta. The placenta is the thing that's giving all the nutrients and everything to the baby. And if the placenta isn't functioning well, it's not going to be able to transmit that over to the baby. So that's when you have your IUGR, your perfusion issues. Those perfusion issues, knowing about preeclampsia and maternal hypertension, is a direct link over to that friend neck. IVH, those severe, even chronic lung disease, because we need the baby to grow in order to grow new lungs. So if we aren't doing those things, then we have these long-term outcomes from a maternal condition. So you can see how this new beginnings is leading us into our whole life. We can have failure to thrive, poor growth. You also will see some absorption issues with these babies. It's very common, especially in your severe IUGR patients. So think about what that high blood pressure is doing and how it's constricting the vessels in and around the placenta that then in turn are affecting the baby. With placenta previa, this is another issue with our old friend, the placenta. I feel like I'm like dogging on the placenta today, and we all know how much I love the placenta. But this all depends on where the placenta is implanting into the uterus. So in our first picture here, we see this normal position where the placenta is up and away, and it's just kind of like doing its job up there. But if it comes too close to the cervix, it can cause bleeding during the second, third trimester of pregnancy, and sometimes it can cause severe and sudden onset of bleeding. Also, if for some reason a woman went into labor and started dilating, the placenta is at very high risk of being injured. And as we know, the placenta is supplying everything to the baby, so then the baby would be in trouble. So placenta previa can cause bleeding in moms, which is dangerous, also dangerous to the baby because of decreased blood flow. I also, when you look at this third picture of fourth picture of total placenta previa, the baby's job is to descend, right, with its head down on the cervix to be able to prime and move the cervix around. If you have a placenta there, your head is just like hanging out on the placenta, which is going to impede its blood flow, in turn impeding the blood flow to the baby. So it can have some of those long-term effects of poor perfusion and whatever poor perfusion goes into, such as NEC, IVH, chronic lung disease. The other big one I wanted to touch on is choreo. Chorioamnionitis is when this is an infection of the fetal membranes and amniotic fluid. And I think that we really kind of get into this idea that this is going to happen with severely prolonged labor, prolonged rupture of membranes, issues with maternal infections, but sometimes it can also come from multiple vaginal exams, the internal monitor that goes on the little baby's head. Anytime that we are entering kind of this place where it was this closed environment and is now an open environment. So bacteria from the genital tract is ascending into the uterus and it's causing inflammation and infection. This can lead to preterm birth, neonatal sepsis, right? Infection in the newborn, and RDS, so respiratory distress syndrome. I do think we know a lot about choreo because we get a lot of babies for kind of rule out sepsis, or that we know that the mom wasn't well pre-treated, that she had a prolonged rupture of membranes or was GBS positive, but maybe didn't get enough antibiotics prior to delivery. I think what we tend to forget is just how profound this can be to the baby, especially if it's not caught early. Great things about this are things like the sepsis calculator that allow our providers to look at the baby's risk factors and decide what the next best step would be. But this is one of those things that kind of the maternal condition that can affect the baby. When we look at gestational diabetes, this is, diabetes that occurs during pregnancy when you aren't producing enough insulin. So these babies are at risk for being larger, being macrosomic. They are at risk for hypoglycemia after birth because, right, the mom has been giving them all this insulin. All of a sudden from her, treatment, all of the sudden the baby is producing that, and the pancreas is like, what am I doing? How are we handling this? And the sugar plummets, right? Hyperinsulinemia is the fancy word for that, with high levels of insulin circulating in the baby, when in turn the placenta's not there. The placenta, I'm talking about again. The mom's not there, and the baby, we quickly need to give them sugar to replace that until it can regulate. What we don't always know is, why do these babies have breathing problems? So a lot of times we contribute it to them being large, or being a C-section, or just having, complications during delivery. But one thing we don't always think about is that insulin deactivates surfactant. So take that in. Insulin deactivates surfactant. So especially if you are a late preterm infant and you maybe already have decreased surfactant stores, now we are decreasing it even further. We're inactivating it. So this hyperinsulinemia, high levels of insulin in the blood, are causing the deactivation of surfactant. So that is going to increase your risk for respiratory distress syndrome. And then, of course, we have jaundice issues. And I also think that these babies are really poor feeders. And I think it comes back to sometimes they're bigger. We think they're going to do better when they actually are quite floppy. Their upper airway muscles aren't well developed. Their suck, swallow, breathe isn't there. So they are not the best feeders that we've seen. So poor breathers, poor feeders, they end up in the NICU hanging out with us. So we come back to my old friend, the placenta. So placental insufficiency, you probably hear that and you're like, okay, like, what's going on here? But really we have to think about that the placenta cannot deliver an adequate supply of nutrients and oxygens to the baby. And anytime that happens, it's going to put the baby at risk for long-term complications. This usually is happening from hypertension, smoking, multiples, poor nutrition, medications that the mom is on, and then the baby in turn is going to have IUGR, preterm birth, or stillbirth if not managed properly. The placenta is the beating heart and soul of this pregnancy. So if it cannot function properly, then the baby is going to have long-term outcomes, which takes us into our old friend abruption, right? Placental abruption is this premature separation of the placenta from the uterine wall. When something is separating, you're going to have bleeding. So this vaginal bleeding, sudden abdominal pain, or sudden abdominal back pain, signs of fetal distress. All of these things are getting the baby into trouble. Babies can also swallow a large volume of this blood. They can breathe it in as they're starting to get into distress and doing the gasping breaths. So abruption also has long-term consequences that you're going to see the baby in the NICU. These are often babies that we will see that need total body cooling or neonatal hypothermia, where they need to be cooled in order to protect their brain. We've got a long YouTube on that. Just go down and find the old one if you want to know more about cooling. But this placenta really does play an important role. And another part of insufficiency that I did want to touch on is the idea that the placenta is a temporary organ. So it is a temporary organ that is meant to last about 40 weeks. Not everybody's has the exact same expiration. But as we get further along in term, and past term and post-term babies, the placenta is going to not be able to function as well. And that's when we're doing those non-stress tests, the biophysical profiles to kind of see how the baby is doing, how the placenta is reacting to the environment, which leads us into oligohydramnios. So oligo is this abnormally low level of amniotic fluid. We think about the importance of amniotic fluid for cushioning the fetus, keeping the baby warm in there. But one other part to remember is that amniotic fluid is what causes lung development. The baby has to have fluid in the lungs to allow them to grow and expand within the cavity of the rib cage and the lung cavity. In the absence of fluid, a baby will have underdeveloped lungs. Now, if you have oligo for a day, that's very different than having kind of chronic oligo throughout your pregnancy. So again, if we are P-ROMed, I remember taking care of a baby once whose mom had ROMed at 17 weeks. And the baby was delivered at about 27 weeks, but kind of that absence of fluid made that baby have a long stay in the NICU. I have said over and over again, I would take a well-grown, healthy pregnancy of a 23-weeker over a poorly grown baby in the setting of oligo or preeclampsia who is 27 weeks. Because that stress and what it's done on that baby in the absence of fluid is going to cause prolonged stay, at risk for chronic lung disease. We can do a lot of things, but we cannot replace the valuable time of a baby in utero, in fluid with their mom. So looking at these babies, twin to twin, postdates. Okay, the postdates is the same thing where the fluid is just not enough. Now, they're not going to have as much of an issue with their lung development because they've been in utero this whole time. But those postdates babies are also going to just not have enough fluid in there for the cushioning and the contractions and everything. So that's when the providers or the OB providers are trying to decide, is it time to get the baby out? So all these conditions really tell us how can we best help our birthing parents to understand kind of what are the things we need to focus on. So regular and early prenatal care, even getting prenatal care before you're pregnant. Prenatal care, before you're thinking about it, if you have that availability, is getting your blood pressure in a good place, getting your diabetes in a good place if you have it, watching those pre-existing conditions, the autoimmune diseases. I think that's one of those things. I mentioned rheumatoid arthritis, but autoimmune diseases are one of those things that are just coming forward more and more with how they're affecting the mom, how they're affecting the baby, and of course, what are the medications that the mom might be on. Thyroid disorders, hypertension, getting moms to have healthy lifestyles, regular exercise, stress management, adequate sleep, empowering women about pregnancy, childbirth, what postpartum care is going to look like. What are the warning signs for, hey, am I in preterm labor? Do I have leaking fluid that could lead to oligohydramnios? Am I having headaches because my blood pressure is getting out of hand? The retained fluid can also be a sign of hypertension or preeclampsia. And then, of course, supporting mental health. It's so important to recognize and address mental health conditions, depression, anxiety. Also, all of these little diseases we're talking about are just going to add to that cycle of mental health issues. So this takes a collaboration. I think we think ourselves like, oh, we're NICU nurses. I can't really control that. I don't do these things. But it is just talking in the community. It's educating for next pregnancies, for next opportunities. What could we do to help, get in the right place with your hypertension, with your diabetes, etc. We can, as NICU nurses, influence the birthing parents around us, the moms, the dads, everybody who is there helping to take care of these babies. So to recap, to really truly understand a NICU baby's course, you must understand the risk factors that come from the birthing parent. Those pre-existing conditions, those things that develop during pregnancy, increasing awareness, advocacy, access to health care is a crisis in our whole country. We know that. And so how can we get, as NICU nurses, we can advocate for increasing access to health care so that we can get on this path to better maternal outcomes, better maternal health. Therefore, we might have less NICU admissions, less premature births, healthier babies, healthy mamas, healthy babies. So that is our first week of March on New Beginnings. Today we talked about maternal health conditions, and I hope you will join us next week. We will cover another New Beginnings topic. More to come on that. I hope you have a great Tuesday, and please comment with any questions you may have.